Everybody who is just joining us now, we are going to take about 15 seconds and give folks a chance to get into our webinar here today, and then we'll go ahead and get started. All right, and as folks are shuffling in here, we'll go ahead and kick off today's webinar. So good afternoon or good morning, depending on where you're located, and welcome to our webinar today on operational and clinical pathways for addressing diabetes and behavioral health. Next slide, please. And so if this is your first time joining us, my name is Andrew Phillip. I'm the Senior Director for Clinical and Population Health here at the Primary Care Development Corporation based in New York, although we have offices in DC and California. Next slide. So just again about us, we're a national nonprofit organization dedicated to really catalyzing excellence and achieving health equity in primary care. And we do this through advocacy, through capital investment, and through training and consultation around a host of different topics. Shuffle us through the next slide here. And just a quick disclaimer for you, this series is funded actually by the SAMHSA Center of Excellence for Integrated Health Solutions, hosted at the National Council for Behavioral Health, and funded by our government. But it's important to note that none of the opinions or views expressed here today are those of anyone other than the presenters, certainly including SAMHSA, CMHS, or any other federal agency. Next slide. So just again, we're about 2/3 of the way through our series here, but the kind of goal of all of this is really to think about how can we maximize the care for people who have diabetes or are at risk for diabetes within the full kind of integrated care spectrum. In particular, how can we bring teams together to really enhance their potential for addressing diabetes? But even if you don't have an interdisciplinary, multidisciplinary care team, how can you really maximize the value of what you bring to the table in providing care or in managing clinics? And finally, how can we look at the processes and practices that are in place to, again, maximize that efficiency and the impact around diabetes? Next slide, please. So this is number 6 in our 7-part series. So we've been going for most of the year now. And if you're, again, if this is your first time joining us, you can find recordings at pcdc.org and at thenationalcouncil.org as well. And today we're going to be focusing again on operational and clinical pathways. This is kind of the part 2 of our operations focus. Last time you joined us for a discussion really around the basics of quality improvement and how do we sort of take that lens. And today we're getting deeper. And so we're going to be talking about how do you actually implement a program like this? And we'll have a great example as well from the field. Next slide, please. So why are we doing this? Again, very briefly, we know that it goes both ways, right? This is a bi-directional issue where people who have diabetes, they're more likely to also suffer from behavioral health conditions, and people with behavioral health conditions are also disproportionately more likely to be at risk for having diabetes. And so we need to look at this issue from both ends. And now more than ever, amidst COVID and everything that's going on, we know that any entry point into care is critical, and we need to provide the highest breadth of services that we can. So that's really the intention here. Next slide. So joining us again for this part 2 here are presenters Maya Morse and Amy Goodman. Maya is a senior program manager here at PCDC. She's an expert coach and facilitator and credited through the patient-centered medical home as a content expert and also oversees our work around billing and coding. Maya has a strong background in health center operations and management, and she'll be talking about that. Amy is also has a background as an LCSW, also a certified content expert in patient-centered medical home and billing expert as well. And she brings us over 20 years of experience in healthcare fields, including DD and behavioral health. And finally, next slide. Our special guest today is Renee Boak. Renee is the Senior Director of Population Health Research and Innovation at Cascadia. Renee also oversees the CCBHC program there, which we'll be hearing more about. And we know this is particularly an exciting area around innovations in integrating care and addressing diabetes, among other areas. So I'll defer to Renee to talk about those things, but we're excited to have you here joining us as well. So without further ado, I'd like to kick it over to Amy and Maya, who are going to take us through the first half of our discussion today.
Great, thank you, Andrew. And welcome everyone. Today we're going to be reviewing some learning objectives. We're going to define the medical home concepts, including health home and CCBHC in preparation for Renee, as well as identifying 6 concept areas related to medical home: access, team communication, care coordination, care management, population health, and quality improvement. We'll also go in and list some statistics of patients with both diabetes and mental health conditions from a social determinants of health perspective. We'll review a case example in Cascadia BHC. And lastly, we'll be discussing sustainability. Next slide, please. So let's do a little bit of level setting and discuss some of these concepts. A health home is a way to coordinate care for Medicaid patients who have complex chronic diseases and mental health disorders. These patients require social support systems in the community. As a care coordinator typically works closely with patients to help them better understand and manage their conditions. And the care coordinator helps to create a plan of care that meets the patient's physical, mental health, and social service needs. Next slide, please. So many of you are familiar with CCBHCs, but for those of you who aren't, CCBHCs are certified community behavioral health clinics, and they're designed to provide a comprehensive range of mental health and substance use disorder services to vulnerable individuals. So in return, the CCBHCs received enhanced Medicaid reimbursement rate based on their anticipated costs of expanding services to meet the needs of these complex populations. The CCBHCs are nonprofit organizations or units of local government behavioral health authority. And they are focused on providing 24-hour crisis care, evidence-based practices, care coordination with local primary care and hospital partners, and integration with physical health care. So that being said, let's dive into medical home. Next slide, please. So here are some 6 common medical home concepts that you may or may not be familiar with. To provide a definition, a medical home is best described as a model of primary care that is patient-centered, comprehensive, team-based, coordinated, accessible, and focused on quality and safety. So these are the concepts to consider as we have here on the slide, whether you are in a traditional primary care setting or in a community-based behavioral health care setting. Let's go into detail now with each of these. Next slide, please. So we're going to focus on access, and the medical home models for access expect continuity of care. In order to do that, we'll be looking at empanelment and access to the medical record and the patient access to the practice. In order to ensure this continuity of care, patients and families and caregivers are provided 24/7 access to clinical advice, and appropriate care is facilitated by their designated clinician or care team and supported by access to their medical record. So as you can see, practices support continuity through empanelment and systematic access to the patient's medical record. So services that are, or concerns that are brought up after hours can be addressed by the care team members with the patients directly. And then the practice considers the needs and preferences of these patients when establishing and updating these standards for access. And if you do one more click, and the practice enhances patient access by providing appointments and clinical advice based on patients' needs. Next slide, please. So these are some quick examples related to access as ways a practice enhances their patient access. They would provide same-day appointment scheduling and have extended hours of operation at the practice. In order to provide same-day appointment scheduling, typically this is often looked at as reserved time slots for primary care providers, maybe one slot in the morning or one in the afternoon or one during the day, depending on the hours that the provider is scheduled. And this would be slots that would be reserved until the day of, and then they would be opened up and available to patients who are calling up that same day. These would be able to be accessed by patients who are, for example, walk-ins. Having extended hours of operation at the practice, so these would be any hours beyond the 9 to 5 hours of a business day. So maybe these would be hours in the evenings, early mornings, or on the evenings and weekends. Running reports is an example of how practices are able to monitor access in order to forecast appointment availability often practices will use a third next available appointment to report. And this is ensuring that appointments are available during the identified timeframes that the practice has indicated. So if practice says we're going to schedule new patients within a 2-week period, we want to make sure by looking at these third next available appointments that they are in fact scheduling new patients within 2 weeks. In order to look at same-day utilization and extended hour appointments, you'll be able to run reports on utilization of those appointment types. And then to manage patient continuity with their identified primary care physician, it's important that we see how patients are impaneled to that primary care provider, and then to review timeliness of clinical advice provided by the practice to the patients. Oftentimes practices will be able to do short logs or reports to ensure that calls that are received to solicit clinical advice at the practice are being monitored through the whole progression, the time and date that the call came in, as well as the response time and date from the practice, whether it be the clinical care team or the clinician themselves. And lastly, surveying patients on their access preferences. So making sure that we find out from patients, communicate with them regularly about when, what kind of access preferences they have, when do they want to be seen, how is it that they want to be treated, and so on, by what kind of provider, and so on. Next slide, please. So the practice provides continuity of care and communicates its roles and responsibilities to patients and their families and caregivers, and organizes and trains staff to work to the top of their license and to provide patient-centered care as a part of their medical home. So the medical home responsibilities, the practice defines and communicates its role and the patient's role in the medical home model of care. So on the left, you see the practice organization, and this is how the practice commits to transforming into a sustainable patient-centered practice. And that care team members have knowledge and training necessary to perform their roles, which are defined by the practice's organizational structure. So we'll talk about some examples of that on the next slide, but team communication is key in this process because communication among staff is organized to ensure that patient care is coordinated, safe, and effective. Next slide. So some examples of team-based care and communication, how the care team communicates with each other. So more specifically, are there daily huddles where the care team meets as a team, speaks about specific patients, talks about who's coming in, who's recently out of the hospital, using their EMR dashboard that may have instant messaging or tasking functions, as well as email and telephone. All of these are ways for the care team to coordinate care for their patients, as well as ways that the practice communicates with the patients themselves through posted flyers, brochures, welcome packets, as well as technology, patient portal, being able to send campaigns via text or through email or regular mail, and telephone as well. Next slide, please. So care coordination. The practice systematically tracks tests, referrals, care transitions to achieve high quality care coordination, lower costs, and improve patient safety, and ensure effective communication with specialists and other providers in the medical neighborhood. So coordinating care with healthcare facilities, this is where the practice connects with healthcare facilities to support their patients throughout any care transitions in the community. And the practice receives and shares necessary patient treatment information to coordinate comprehensive patient care. These include diagnostic test tracking and follow-up, where the practice effectively tracks and manages laboratory and imaging testing, important for the patient care and informing patients of their results, as well as referrals to specialists. Practice provides important information in referrals to specialists and tracks referrals until the report is received. These two pieces enable practices to have the ability to close the loop on receiving information from external sources. Next slide, please. So some care coordination examples include ways that the practice tracks orders and referrals and hospital visits. So practices will review their workflows and they will run reports related to tracking these labs and diagnostic testing orders and referrals, making sure that consults were received from specialists within the time frame that's indicated. Oftentimes practices are tracking on anywhere from a daily, weekly to monthly basis to ensure that all of these different types of orders and referrals are received. And this helps to identify gaps in the process. So practices will often note maybe different types of referrals to different specialists are coming in more timely versus others. This is an opportunity to address that gap and communicate with specific specialists that might not be providing information as timely. Additionally, any kind of lab work or diagnostic testing, anything that doesn't come back from the labs or radiology, these are areas in order to communicate with the external sources or internally, depends on how you are laid out. And then reviewing workflows on transitions of care and how we're tracking avoidable ED hospitalizations with the patients when they go to the hospital. All right, next slide. So care management, the practice identifies patient needs at the individual and population levels to effectively plan, manage, and coordinate patient care in partnership with patients and families and caregivers. The emphasis here is placed on supporting patients who are at highest risk. So we're identifying care managed patients by systematically identifying these patients who may benefit from care management. So this would be risk stratification of patients who are at higher risk for needing additional support in order to better manage their health and care service needs. And care plan development, so patients who are identified for care management, the practice would consistently use their patient information and collaborate with the patients in order to develop a care plan that addresses barriers and incorporates patient preferences and lifestyle goals that are documented in the patient's chart. Next slide, please. Care management examples here would include ways that the practice provides care management, developing a risk assessment of patient populations based on mental health, chronic conditions, and so on. And you could also include their propensity for avoidable hospital visits. They run registry lists based on ICD-10 codes, test results, and counter types, for example, post-hospital follow-up. So this is where you can create care plans that address barriers to care, patient self-management, and patient functional lifestyle and treatment goals. It's a way to ensure that patients receive a copy of their care plan, which was developed with them and their care team staff during their visit. And now I'll hand it over to Maya.
Hi everyone, I'm Maya Morse. Okay, next slide. So population management is really all about data collection. So what we're hoping is that practices can capture and analyze information about their patients and the community that they serve in order to deliver evidence-based care that supports what the population needs and is provided in a culturally and linguistically appropriate way. And so, you know, what does that really mean? Well, we need to collect all our data. We need to think about what sort of populations we serve. And so it's oftentimes we work with practices to really analyze their own data related to race and ethnicity, language, and a whole variety of possible barriers to care. You can also look at your community as a whole and sort of analyze it that way. There's a lot of public data and we tend to do both. Once we know a little bit more about our population, one of the key areas that is often affected is medication management. And so we like to take particular emphasis on that. Many of you are probably very compliant with your medication management, but it can be nice to look and stratify medication management by one of the potential barriers to care, for example, race and ethnicity, and see what fleshes out. Next slide. And so evidence-based care, the hope is that we are providing evidence-based care always, and that we have good guidelines in place. In fact, many of you probably have evidence-based guidelines that are incorporated seamlessly into your electronic health records. And actually a lot of the templates and clinical decision support, those annoying pop-ups, those are actually, you know, worth reading. They are usually guided by some really good evidence-based guidelines. And finally, you know, the last piece is not just connecting, of course, with our specialists and other medical providers, but really looking at connecting patients with community resources. And this can be done in a targeted way. It can also be done more broadly. And we're noticing that some of the compliance organizations are pushing us to actually track that information, track referrals to a community resource the same way we might track a referral to a specialist, and even follow up with the patient and find out, you know, was it effective? Was it a great resource for you? Was everybody friendly accommodating, or, you know, should we look elsewhere for that type of service? Okay, next slide. So some population health examples. This is often, you know, what we do with practices. We help them run lists of patients you could with mental illness, and you could stratify it by race or ethnicity or some other pertinent social determinant of health. So some possible lists. Certainly we could look at diabetes screening rates. It's always interesting to see, you know, your A1C, that's an outcome measure, see how patients are doing stratified by race and ethnicity, adherence to medication, referral to community resources, and even just confirming a visit with a specialty provider or other community resource. You know, even just getting in the door is a good next step, and it's nice to be able to look at lists to provide follow-up as needed. All right, next slide. Okay, so quality improvement. We like to think about quality improvement in 3 different general categories. So first, you need to measure your performance. That's the raw data itself. Many of you probably have a panel of metrics that you're analyzing, hopefully on a regular basis. Then once you have those metrics and you can look at them longitudinally, you know, perhaps every quarter, perhaps you're running data monthly, you can actually set goals and make some actions to improve your performance. That's where we come in. We work a lot with practices to do some short-term plan, do, study, act type cycles. That's what we talked about during our last webinar 2 weeks ago, but really doing some short impactful strategies so that we can see incremental change over time. That's our goal. And then the third area is reporting our performance, and make sure that this is not forgotten. We want to make sure that we're sharing our performance with the other members of our practice, and you know, not just providers, but really the whole team, because we're all working on it together. Next slide. So what are some QI examples? Well, we could establish a QI initiative to increase diabetes screening among patients with depression and severe mental illness. That's a process measure, so should be able to be achieved during a rapid cycle testing model to make sure that we're, you know, consistently asking patients to be screened. Perhaps we're implementing a pre-visit planning process so we can identify which patients have diabetes and should be screened during that visit. You can also perform outreach and have them come in if they haven't been seen in a while. Okay, next slide. So we thought it might be helpful to just share some diabetes statistics. We sort of dug into the internet and found some really interesting studies. So people with diabetes are 2 to 3 times more likely to have depression than people without diabetes. People with severe mental illness are more than twice as likely to have type 2 diabetes, with even higher rates among patients who are African American or Hispanic. And that was according to a 2018 study. And people with severe mental illness have lower rates of screening for diabetes. That's really important, and that's something we can start making changes in our practice today to make sure that we are screening patients with severe mental illness for diabetes. Okay, next slide, and I believe we are passing the baton over to Renee to talk about her work at Cascadia. Thank you, Renee.
Hi, good morning and good afternoon, everyone. My name is Renee Boak, and I'm the Senior Director for Population Health Research and Innovation for Cascadia Behavioral Healthcare out in Portland, Oregon. Next slide, please. So I'm going to talk a little bit about Cascadia and our journey into integrated care and how we ended up doing the diabetes work that we're doing. So we're a nonprofit organization. We have, I think currently we have over 1,000 employees, and we serve anywhere between 15,000 and 18,000 people a year. In addition to outpatient, residential, and community-based services, we also hold the contract for the county crisis system for the Portland metro area. We're located in 4 different counties, primarily in Portland Metro, though we do serve some individuals a few hours south of here. 75 different locations, including clinic locations, housing locations, as well as residential and supportive housing programs. 4 different integrated health clinics with over $70 million in revenue a year, and then in addition to that, about 750 housing units. Next slide, please. So the mission of Cascadia is to provide whole person health care, integrated mental health and addiction services, primary care and housing to support our communities and provide hope and well-being for those that we serve. And what we envision is a community where everyone benefits from whole health care, experiences well-being, and has self-directed, connected life. Next slide, please. So I just want to spend a moment talking about some of the services that we provide at Cascadia. Within our health center locations, 4 of them, we do centralized intake. We provide services to adult mental health outpatient, adult SUD or addictions outpatient. We have programs specifically for child and family, older adults. We'll jump into this more deeply here in a few minutes, but we recently began providing primary care services as a result of the CCBHC opportunity. We currently have, 3 primary care clinics, and we are in the process of adding 2 more sites, one in the 4th clinic, as well as one in our supportive housing programs, which is a 50-unit single-room occupancy program that also provides services on site. And we also provide urgent walk-in services for individuals on the psychiatric side. In our community-based services, we have both ACT and FACT, so forensic ACT programs, intensive case management. We work with individuals who are under the forensic systems who are part of the Psychiatric Security Review Board. We do a lot of work around housing outreach and street outreach, getting people into services and engaged. Again, our crisis services, which also include several respite programs, and then our residential and supportive housing services. Next slide. So we have a lot of teams and programs that support the service providers from the administrative perspective. So I just want to call out a few. Business intelligence. So this is our report writing team, and they are critical in supporting everyone in the agency and being able to do their work. Without the data that they can provide at the regularity that we do, there's just no way that we can understand, both the state of health of our clients and whether or not we're making improvements, how we're making improvements. We have a communications team, which is really helpful in pushing out communications to staff, to clients, internally, externally, to our partners. So communications is key in sharing our efforts. We also have the privilege, I guess, of having 2 different EHRs. When we're a behavioral health care organization, so we work with Credible as our EHR. But when we brought in primary care, we realized that there is no one record system that will serve everyone well. So we're now using Ocean Epic for our primary care services. And then I think another key team to point out is the Population Health Research and Innovation team. So for so many years, Cascadia has been working towards becoming a whole person integrated health agency, and we've done that, and that is really amazing. But now that we've done it, our goal is to improve the health outcomes of the people that we serve. So that's why we created this team. Next slide. So I just want to spend a few minutes just talking about our different team members because everyone plays a really important role. We work with individuals who are peer providers, both on the mental health and the SUD side. We have individuals who are case managers and skills trainers, so individuals who have a 4-year degree in psychology or sociology. We have our counselors with the master's degree, and then we also have our licensed counselors. We have addictions counselors, and when we brought in primary care, we had the opportunity to add a couple of new positions in addition to primary care providers. So medical assistants, that's something that's new to Cascadia within the past couple of years, as well as care coordinators and panel managers to really engage in that population health approach. We have nursing staff, of course, and we have a whole bunch of medical providers. We have medical doctors, we have nurse practitioners, physician's assistants, psychiatric nurse practitioners, a lot of different medical providers. Next slide, please. So just taking a moment to talk about the Population Health Research and Innovation team. We're a small team, but mighty. I have the pleasure of working with a director, a project manager who has been crucial in our implementation and oversight efforts for so much of the work that we're doing. We have a population health analyst. We'll be adding an evaluator to the team as a result of being a recipient of the CCBHC expansion grant. And we're also adding complex care manager. So this position is going to be focusing specifically on individuals who fall within that high utilization rate within emergency departments. Next slide, please. All right, so let's get into diabetes. So before CCBHC started, which was in, it was in 2017 to 2019, Oregon was one of the 8 demonstration states. And before CCBHC, we only had one EHR. We had some information about medical diagnoses in the record, but it wasn't consistent. And we had some information about risk factors, but again, not consistent. And examples of those risk factors might be A1C, BMI, things like that. After CCBHC, we had 2 EHRs, which certainly adds some complexities, provides us with an opportunity to have a lot more rich information, particularly for individuals beyond, just the information outside of behavioral health. A lot more information around medical diagnoses and risk factors, more consistent information around health outcomes, whether it's A1C, BMI, your basic metabolic panel. A lot more care coordination, and the reason that we have more care coordination is because when we became a CCBHC demonstration state, our model include care coordinators. So each of our health clinics has 2 care coordinators attached to the team, and they have really been crucial in coordinating care, both internal to the agency as well as external. And then again, the population health team is new to Cascadia, and the role that we have is really around project management and implementation. And kind of once we have things set up and stabilized, then we can transition that over to the clinical teams for maintenance. Next slide, please. So the reason that we're talking about diabetes today is because, for many years we suspected that we had a lot of individuals who have diabetes at Cascadia, and with the advent of CCBHC and our second EHR, we had the data to back that up. We know that the impact on our patients is high, we know that the cost is high, and we know that we have an opportunity to do better. So we really started to dig into our work with diabetes. We're very fortunate to receive 3 separate grants to support a pretty holistic attempt at improving health outcomes for individuals who have diabetes at Cascadia. So part of those grants was really around project management, implementing the model, doing some panel management and care coordination, and then evaluating the efficacy of the program. So we're just going to kind of walk through that. So why don't we go to the next slide? Okay. So when we think about the diabetes program at Cascadia, our first go around, we targeted our 4 health centers and 2 supportive housing programs. And we targeted these locations because, one, we knew there was a high prevalence at these sites, and there was also a willingness and buy-in from the staff to engage in the diabetes work. And I think that's really important because doing work or providing information, support, skills training around diabetes in behavioral health is new, and not everyone feels comfortable or like they have the skill set to do that. So we were really looking for our early adopters and working with them and providing them with the training and the support and the tools that they need to engage in this. So when we're thinking about our populations at these 6 different locations, we engaged in some targeted outreach efforts. We first looked at individuals who were engaged in primary care because we have a lot more information because we have that second EHR. But we also took a look in our behavioral health care EHR and looked for individuals where we have things like information around A1C, self-report around diabetes, having that, anything that might suggest that this person is at risk. So once we identified these individuals and we provided the training to the staff, we started looking at the interventions, and we decided on the TTMI curriculum, and we're going to go into that in just a minute. And in terms of the facilitation model, we felt it best to have a co-facilitation model, and this was either co-facilitated with a peer staff and a nurse, or a peer staff and a master's clinician. And I think that's really important because my experience in working with peers is that they can really speak to the challenges of what it's like to cook when you live in a single room occupancy and may have a microwave or a hot pot, or what it's like to be able to buy diabetic friendly food when you have food stamps and maybe have difficulties traveling to the store and getting fresh fruits and vegetables. So the peers are really able to speak to this experience because they've experienced it. The care coordination piece was key in this pilot program because Allie, the care coordinator, she did not only a lot of work to coordinate care across behavioral health and primary care internally, but for individuals that were part of this pilot that were getting primary care outside of Cascadia, she worked with their providers, making sure that we're connecting and on the same page around services and getting data from them and entering that into our EHR. And then another big part of this after the formal interventions wrapped up is getting feedback. So we got feedback both from the clients participating in this experience as well as the staff who were facilitating the supports. Next slide. So I just want to spend a few minutes talking about what the curriculum looks like for the TTMI curriculum. And I'm probably going to speed up my my pace of speaking here because I think we only have about 10 minutes left. But what I like about the TTMI curriculum is it's fairly holistic, and it's a nice kind of seminar type group where each week you have a different topic. So you set your ground rules and go through a basic orientation. Week 1, session 2, you talk about some of the challenges specifically around having mental illness and diabetes. And we're not going to go through all these because you can see we talk about some of the benefits of diabetes complications and then the benefits of sugar change. It spends some time talking about problem solving skills and the resources that we have available both internal for Cascadia clients as well as outside of the agency. Next slide. Session 7 focuses on substance use, which I think is all really important, and we don't always highlight that. Session 8 is really looking at physical fitness and emotional health. I think this is another really good place to bring in our peers, individuals who can speak to how they've been able to creatively engage in physical activity when they may live in an environment that doesn't have sidewalks or lighting, so they can be outside walking safely at night. Of course, spending some time talking about medications, social supports, an entire session on taking care of your feet, and then just ongoing lifestyle management. Next slide, please. All right, so I just want to share with you some of what we learned about our patients who participated in this project. So the engaged clients, on average, 56 years of age, 71% identified as white, 74% identified as having type 2 diabetes, and of those, 25% had a recent diagnosis. So for the individuals who participated in the groups, we had 31 clients and attend at least a third of the session, so between 3 and 4, and more than 84% attended at least half, and we have full data on 17 participants. So I think it's really important that when we're asking people to do new and different things, especially our staff, that we are able to provide them with information and showing, what it is that we learned and how we impacted the population. So this is what our population looked like. Next slide, please. So in terms of outcomes, we saw a 1% decrease in A1C, and as it's associated with other lower health risks, we saw a 25% decrease in some microvascular complications, 19% decrease on risk around cataracts, and 16% decrease with heart failure, and 43% decrease in amputation or death due to vascular disease. So we saw some pretty good improvements early on for this pilot, considering it's only 10 weeks in length, and we were able to see some small decreases in A1C. And I think what's important to share with the group is that we know that behavior change takes time, and that a 10-week pilot is not going to show all of the the movement made as a result of this. So after the pilot, we've continued to follow up with these clients at regular intervals to make sure that they're getting the support and the resources that they need, but also to ask them questions just around A1C and to make sure that that their health outcomes are trending in the right direction. Next slide, please. Ooh, I cannot see the bottom of the slide. That's okay. What we saw is, you guys, I'm sure the group will be able to see it in the full slide deck, but I can't see the bottom of the slide here, but that's okay. What we found is individuals felt like they were reporting feeling more efficacious in managing their health. They have improved confidence around how they feel around their ability to manage their health, and specifically their diabetes, as a result of this pilot program. Next slide. All right, okay, so what we see here is that improved diabetes for self-management, we see that I'm sorry, I'm having a hard time, I'm not able to see the whole slide.
Renee, you've got on the left side there, you've got general diet, followed by high-fat diet, and then lastly glucose testing on the bottom.
Okay, so what we're seeing, again, it's our clients have an improved confidence around their ability to manage their diet. They have more confidence around recognizing what is and isn't part of a high-fat diet. And there's also more confidence around their ability to engage in regular glucose testing. Next slide, please. So some of the feedback that we got from the participants, I just want to share it with you because when I think about data, I often think about my audience, because who's in my audience is going to dictate the type of data I share. And when I'm talking to people in leadership positions and administrative positions, people who are concerned about money, I use a lot of my my quantitative data, right? I have, this is how much money we're saving. This is what this is, you know, all the hard numbers around improvement. But when I think about getting buy-in from the staff that are providing the services, it's more of that qualitative feedback that's important. So we want to share the impact that this has had on our clients. So one client said that my mood and mental health is intricately related to physical health. So if I'm not feeling like I'm very happy, I check and see how I am doing physically. Another person shared, the best thing I found out was about my teeth. That was the most helpful. I didn't realize how much diabetes plays with your teeth. I learned how to speak for myself and to talk about what my needs are. And I learned that being a good listener when the doctor tells me what to expect taught me to work with her, taught me to work more with her. The group leaders shared with me and I shared with the group leaders. It was a mutual thing. It was the little things you don't think about all the time. Next slide. So again, just kind of jumping back into the data and how we share data. Of course, we have to share it with our grant, the people that provide us with the grant and our funders. We think it's important to share data with agency leadership. We want our agency leadership to be aware of all of our, pilot projects and our PDSAs and see what we're engaging in, where we've done well, where we still need opportunity for improvement. We share broadly the data with staff and clients, both connected directly with the grant work as well as, not connected with it. We share information on our homepage, which is called Inside Cascadia. We've provided information to the media around some of our more successful pilot endeavors as a way to share that with the community and to connect with other providers as well. And then we also share information at conferences and webinars to continue to learn from other people and to share some of our successes. Next slide. So in terms of next steps, we are done with the pilot phase. So we're going to be transitioning this out of population health, which is kind of overseeing the pilot, and it will be seated within our health outcomes program for maintenance. And these, population health and health outcomes will continue work very closely together to maintain the integrity of the pilots, while also making sure that these can be spread out more broadly across the agency. We're really focused on understanding our health disparities and inequities that exist among Cascadia's population so we can better provide culturally specific services or culturally informed services. Some of the steps that we've taken recently is that in addition to being a CCBHC and a CCBHC expansion organization, we're also pursuing FQHC lookalike status. So that has been an interesting exercise in data reconciliation across the two different EHRs and all our reporting requirements. So now that we've done that work, I feel that we have much more rich and robust data around race, ethnicity, sexual orientation, gender, much more in line with how the medical organizations collect that information. So I think we're going to see some really great things in the next 6 to 12 months that we can begin engaging on more culturally specific work and addressing those health disparities. So again, in terms of next steps, we're thinking about how we can, set people up for success when they join Cascadia. And an example of that is just reviewing job descriptions and how jobs might shift a little bit as we embark on more integrated care. An example of that is having our nurses on the mental health side really began to engage in more chronic disease management, group education, and health promotion. That's not something that has been consistently done, at least at Cascadia, amongst our mental health nurses, and this is a real opportunity. So that's kind of what we're thinking about right now. And of course, in terms of next step, the data always kind of leads us to what opportunities are out there. So we're always reviewing our data and looking for both internal and external opportunities. Next slide, please. And I think that is it.
We'll switch back over. Thanks, Renee, to Amy and Maya for a couple closing remarks, and then we'll head over to the Q&A.
Great. Thank you, Andrew. Thank you, Renee. That was so wonderful to hear all about your CCBHC and how it's had an impact on your patients with diabetes and where it's taking you next into the future. So let's build on this and talk a little bit about sustainability and how to sustain a medical home culture. So many practices may have focused their data efforts on producing information related to payment incentives and not yet harness their data for quality improvement. So as Renee has been talking about, collecting your data on also your clinical measures and metrics that you're looking to address and help push the envelope on better outcomes for your patients, specifically for diabetes, as she described. Trusted and trained team that has tools to do their work and is how a practice can influence the success of their medical home, identifying which staff can do specific roles, type of health education or care coordination, as well as seeing which roles maybe you don't have in place and other staff that you would bring into the team. An EHR is a business tool that should help to maximize productivity and support reporting efficiency. So having familiarity with the systems to ensure proper data entry, this is critical. And having more than one brings an added complication, but absolutely more information, making it a richer environment for you to be able to understand your populations better is definitely worth it. And then developing a routine display of practice data using a dashboard. We saw some graphs during Renee's presentation in order to share with team members and leadership, and how you share on your intranet as well as on your website with patients and the public in general. It's really important that people who get to explore your organizations to understand better what your success is, what your challenges are, and to learn more about the services that you provide for your patients, especially as it pertains to having integrated care. So that's all we have for us. I think, Andrew, I'll send it back to you.
Great. All right, thanks everyone. So we have a nice list of questions as well as comments that participants have been sharing. And so I'm gonna go through a few of them and we'll get through as many as we can. This first one, Renee, I think this is certainly directed to you. So you had mentioned those two electronic health record systems, which I think is a play that many folks are aware of. So question is, do all the providers have access to both of those systems? And has that decision had any kind of impact on the continuity of patient care?
Yeah, that's a great question. I mean, we could probably spend 10 minutes just talking about how we're defining provider in this case, right? So we're a behavioral healthcare organization. So I would say probably 98% of our staff are using Credible, our behavioral healthcare EHR. When we started with primary care, of course, all of our primary care team has access to the the medical EHR, to the physical health EHR. Our care coordinators are probably the individuals that the position that works most commonly back and forth between the two different record sets. They have two monitors, and they usually have one EHR in each monitor, and they're going back and forth all day. I think some medical providers who are on the behavioral health care side have access to Epic, but really it's individuals in primary care who have access to Epic, individuals in behavioral health having access to Credible, and some exceptions based upon need, but it's not, hey, everyone has access to this. It's more based upon need. And I guess maybe just to provide a little bit more context around that, it's not just Epic the record, but it's Ocean Epic, which is a collaborative. So there are a number of medical organizations around Portland Metro that are part of this, which, we certainly, that's advantageous because hospital information and all that, is in there, but we also need to think about who has access to that information internally. So it is restricted, but it is made available based upon need.
And Arthur had a nice follow-up question to that. Anything that you're doing to kind of integrate these systems further? We know this is, it's an expensive and kind of laborious process, so sometimes impossible.
Sure. We were a recipient of SAMHSA's PBHCI grant back in 2013, the Primary and Behavioral Healthcare Integration Grant. And I was fortunate to be part of that. And I remember even back in 2013, people were telling us that the record systems were going to be solved, that there was going to be integration, and there's not. So right now, the best that we can do is identifying those key data points that we want to have in both EHRs and making sure it's in there. But also, using our business intelligence team and forgive my lack of tech savvy words, but we have a data warehouse where the information from Credible goes to it, the information from Epic goes to it, and then when our analysts write the reports, the information is pulled from the data warehouse and not the individual record sets. So that's kind of like the best that we can do right now, because there is not a behavioral health care EHR that can meet the complex needs of primary care, and there's not a medical EHR that can meet the needs of a complex behavioral health care organization.
Yeah, we know it's frustrating, and I know this is even more complex, in dealing with like housing and other needs that also pull for unique components of the EHR.
Yeah.
So next question, this is for, I think this is for Maya and Amy. Talking about those risk assessments that are available, any suggestions for which ones to use? Is there anything that's kind of easily accessible or available for folks who are in organizations that are kind of just going down this road for the first time?
I can start with that, Maya. I think that a lot of the risk assessments that we've worked on with practices, many of them are focused definitely on primary care, because that's really where the push has been. I think the way that practices can look at risk assessment is something very personal or very, specific to the organization. So if you have information related to your patient population, those demographics, how the patients utilize the practice, how many visits they have, or how they utilize the emergency department or hospital, that information in conjunction with, say, the patients that you are providing care management with. Those are those higher risk patients. I think how you stratify the patient panel across those that are healthier versus those that have maybe two or more chronic comorbidities, that will help to risk stratify, as a practice. But as far as a standardized tool that would be beneficial, I'm not sure of one that covers for behavioral health. I'd have to look into it. But if I find anything, definitely I'll send it your way, Andrew.
Thanks. Yeah, and I think to your point, starting with what you got is really what's most important here. And so, I know some clinics will work with even just the basic Excel spreadsheet tool. I think Aim Center has some samples of that kind of thing. But and Renee, I don't know if particularly in the early days of doing this, if you had a starting point that you used, before some of the other opportunities came through.
Yeah, I think we based our model based on, CCBHC requirements. And a lot of things we were asking about, we weren't just necessarily engaging in the follow-up requirement that, CCBHC has of us. So we ask about tobacco cessation, so I think there's not a standardized tool. I think it's looking at the requirements that you have, the data that you already have, and thinking about what works and where you have opportunities maybe to dig a little bit deeper and make that more actionable within the practice.
I wanted just to add, I think the data warehouse tool as in and of itself is very valuable in order to help be able to merge the data from both of those systems. That'll help give you a fuller picture of the patients as well and be able to categorize them across a level of risk.
Yeah, and it's a lot of work to reconcile the two different EHRs. We've been at this, I think, 2020? A little over 2 years now, and we've done some really good work, but it takes a long time, because if you don't have if you're not reconciling the two EHRs against each other, then you can't be confident in the validity of your data when they're disparate across the two systems. So a lot of work and a lot of energy and a lot of staff time was put into it, but I think we're going to get some really good outcomes because of it.
Great. And Renee, another question that came through was around some of the team roles, in addition to what you described. So, you had mentioned peers, but anything around do you use folks who are going out in the community, like community health workers or others, or the peers doing that? And then there's a part two, which is around the use of pharmacists. I don't know if you have those integrated.
Yeah. So we do a lot of community-based services. We have peers that are connected to our housing outreach and street outreach teams. I'm very much part of that, so absolutely. With CCBHC, we had the opportunity to add, traditional health workers to our addictions team, which was, really important and, long overdue. Around the pharmacy, we do not have a pharmacy at Cascadia, but, a few years ago, we were undergoing some changes with our pharmacy partner, and we had the opportunity to work with Genoa, and we now have a pharmacy in-house. So it's seated at one of our clinics, and they only serve Cascadia patients, which is really nice because we have a lot of individuals who kind of fall into that long-term, who live in our residential programs that, need a lot of support around medications. So it's been really helpful to have that partner and have a pharmacy specifically dedicated to Cascadia. They're very open and amenable to, getting medications that we need. We've done a lot of talking around Narcan, and making sure that we have those readily available. And they're happy to do that. So it's great to have that partner. And it's also nice not to actually be the pharmacy owner because of some of the risks associated with that. I wouldn't be surprised if we reconsider that in some years down the road once we, with FQHC and the opportunities that that brings. But it's been nice to have a partner and to learn more about pharmacy, clinical pharmacist role from that perspective.
Thanks. And we're going to do a couple more questions, but in our last few minutes here, Chaim, if you'll just advance us to the contact information slide if folks are kind of jotting anything down there. Another question, I think this is an interesting one, and to anyone who has thoughts on this, but talking about some of the variables that tend to be implicated in the development of diabetes, and the question was specifically around African Americans, and if there's any data that we've seen there, Renee or Amy or Maya, anything that you've seen.
I can speak from, just what we've seen at Cascadia. Portland is a fairly white city. I think our demographics at Cascadia, support that. So we do have, we of course serve, Black people, we have Latinos, Native Americans, Native Hawaiians, Pacific Islanders. What we're challenged though is, one, not only finding really good evidence-based practices that are culturally specific, but also just from an implementation perspective, if across the, if we're going to have a group, we need to make sure there's enough people of that group at a particular site to be able to provide those services. And we're just not there yet. So I think that's been the challenge, is having kind of the knowledge and awareness and knowing what we want to do, but just not having kind of enough people to quite do that yet. So that's definitely an area that we're still working in.
I think, Renee, you bring up a really good point as far as that, hitting that tipping point to be able to do those kind of services. With the influx of all this technology and being able to do things from a remote way, maybe there's some kind of, discovery that not just your area, but maybe, another town over, or, being part more of the whole state, that a collaborative could be developed in order to address some of these things.
Yeah.
I think this is really highlights an important area too, which is, we know that a lot of medicine and indeed, other areas as well have really been founded on kind of like white medicine, frankly. And so we need to do more work in this and have to understand populations. And also, we know that there's social implications as well, and our systems support those things. So we'll do just one last question here, and I think this is particularly timely as well. Any changes around COVID, particularly when we're talking about interdisciplinary teams around diabetes, where there's blood work and things like that involved? How are you addressing that? What has that been looking like?
Changes. So we're fortunate that we've been able to engage in a lot of telehealth, telemedicine, telephone services. So we are still largely not providing in-clinic services, so we're starting to move in that direction. I do know that for individuals that were part of this pilot, our care coordinator did do some outreach over the past couple of months, just checking in with folks as part of some of the formal follow-up for the pilot, but also to kind of check in around what's going on now and if people need extra support, and then connecting folks with that. We're probably not going to see some A1Cs for a little while because people aren't coming to the clinic and getting that tested. So we're still very much in the thick of it, and I think we're going to start reintegrating back into the community slowly, but it'll be a little while, and we'll have to see where we can continue to provide services via technology, like over the computer, versus what needs to be provided in clinics so we can have it paid for.
Thanks, Renee. It's been a stressful time, especially around diabetes and these other conditions where we really do have to monitor and track, right? And then also figure out new ways to engage with our teams remotely. So Renee, Maya, Amy, I really want to thank you all for joining us today. We're at the end of our time, but you have everyone has Renee's information there on the screen. In addition to mine, we get the same formula. So it's agoodman@pcdc.org and mmorris@pcdc.org to reach any of us. And we're happy to stay in touch. And I shared the link for the information for today's recording, but we'll also send you out an email with links to the slides and the recordings following today's event. So thank you everyone for joining us. Thank you to SAMHSA, to the National Council for Behavioral Health, and to our team here at PCDC for supporting this effort. And we will see you next month for the last part of our series here. Thanks, everyone.
Thank you.
Thank you.
Well,